graduated from Nebraska, University of Nebraska. I won't tell you what year because I'm still the youngest one in this room. But I've been practicing over 40 years, and then I did my residency down at University of Florida, or after in Nebraska. But then I got my first job at University of Florida. So that's my little background. I've always been in academics, teaching, and leadership. To start out with, I'm very excited to be here with you all because this is what we need to do more often. I'll be honest with you. As a pharmacist, there's a lot of medications out there. I will keep it on time. However, if you have more questions at the end, I'll be here as long as you need me afterwards. I just don't want to keep the whole mass over time, okay? And I encourage you to raise your hand, ask questions. This is not a lecture. I do have position at College of Pharmacy in 6 different colleges, but this is very informal. My role here is to provide you the education that you need, okay? So if I speak a little bit too fast or using the wrong terms or too complex, raise your hand and I'll be glad to clarify that for you.
Would you run cell phones, silence your cell phones?
Oh, that's fine.
I'm gonna grab mine, silence my cell phone.
Yeah, I'm okay. I got my own that
Well, I'm gonna silence mine. Okay.
Yeah.
I did.
Okay, if you want to, it's fine. Like I said, it's so informal.
Yep.
So let me start out with what my goal here today is know your meds. I can guarantee of all you in here, there's no way to go through every single one. So I'm gonna take categories. And before I start, you should have 3 items with you. One is the color bifold, that is your handout. So you can always use that as a reference. The second item is supplement. And here is my pharmacy resident, Leanne. She's training under me, so this is one thing that I encourage you all to at least put your medication list on. It's trifold. If you need more than 1 card because you got a longer list of meds, feel free to pick some up on the way out. And then when you're done, when I'm finished, I bought some gift for you. This is, I call them unisex pill box. Because it's small enough for me to put in my pocket. Now, if you're female, you can always put a bigger one in your purse, but grab some. I got it up here too. I did not get a chance to pass that out. But back to the calendar, the reason it's important is when you're healthy like you are now, you know your meds. I'm taking this drug at what time and at what dosage. But most of the time, I've been an ER pharmacist or worked in the emergency department, is that when you're really sick, you don't remember your drug, okay? So this is good prep work before you go see a doctor. So put that on there and update it as much as you can. That really speeds up the process through the emergency room or urgent care. Otherwise, we're gonna spend a lot of time asking you what medication, and it tends to slow down your care on that, okay? So that's that. Okay. Again, please raise your hand if you have any questions. So this is not formal. So here's the flyer you have. So and we got a number here that you could call. It's our central pharmacy department. If you have any questions, you know, you can ask for Way, and they usually transfer me to my phone number, my office, or so forth. So that's for your information. So let me start out with 3 questions to ask about your medications. So this is you as an individual. If you see a doctor, they usually give you a prescription, right? Or they e-prescribe now. Like, what pharmacy is the one you go to, and then they hit the button that sends to the Walgreens. You know, who knows? There's about 10 of them within a 5-mile radius around here. But it's electronic, and that's what the future is, because you're not going to have a piece of paper prescription. But 3 questions you need to ask about your meds. First question, what is the name of the medication? Okay, I can tell you on the other side, as a healthcare provider, it doesn't help me when you say I take 2 white tablets a day, or even a purple pill. Okay, there's not a lot of purple pill. Okay, so know the name of the medication. Now nowadays, you know, it's easier for us to remember the brand name. Okay, like I take Lasix, but the generic name is really more effective. 90% of your medications probably is generic, okay? If it's not generic, you're paying a lot of money for it too, like Xarelto, Eliquis, those are trade names, but there's generic names. So when it falls off patent, then it goes to the generic name, okay? So know the name of your medication. Why do I need to take it, or what is it for? That's huge, that's really important. And, you know, if you're on even 5 prescription, and that's pretty low. I mean, I could say average out there, and I will use myself, you know, is, I'm not 21, as you can tell, but when you hit the age about 60, 65, the average prescription number that most people have is about 4 to 5 on the low end. Now, some of you probably have more, but I'm not gonna ask you to raise your hands or anything. But know why you're taking that. Okay, even as a vitamin, why you're taking it. Okay, some is it for, you know, better vision or certain reason, or osteoporosis, vitamins. So know why you're taking the drug. And the third question is, has anybody gone over the side effects of those drugs? Okay, and I'll tell you, as time goes, we got to be advocate for ourselves. And as a pharmacist, that's the first thing that we, working with my residents, is like, you need to connect with your patient and tell the patient, this is your medication for your blood pressure, let's say, these are your side effects that might cause constipation, this is for your pain that make you a little dizzy or make you a little sleepy. It's so important to know that. And the reason is, when you go up to 5 or 6 medication, it might be additive. But more importantly is, I'd rather teach you prospectively before you find out that, oh, I got a little drowsy and I fell down, and the consequence, you might break a hip, break a bone, and so forth. So we're trying to encourage, and that's why I'm here today, is encourage you all to have some information before something happens. Anticipate what will happen. Does that make sense? So that's what the flyer here. Yes.
I do.
Yeah.
Here's my question. How, as far as patents on medicine go, how long does it take for that to be over with?
Well, it's
like,
interesting.
I'm thinking of Eliquis.
Yes.
Highly expensive.
I'm sure you're not the only one that's taking Eliquis in this room here, and it's not cheap either. To answer your question, the question is about patents. How long is this? Patent legally is 17 years. Now, sometime there is justification over that 17 years to extend that patent too. But I think your point here is, when does it become generic, so it'd be cheaper?
Right.
That's my focus of the presentation today. And so it depends on what medication. We as pharmacists, I mean, we get, let's say, the next 12 to 18 months, which drug is coming off patent. And that's the key thing. And to answer your question, you're taking about Eliquis?
No, my husband is.
Okay, oh, I'm wrong.
Yes, Eliquis.
Eliquis, they just extended that another 5 years, 3 years, yeah. Yeah,
It's right now.
20 years.
So
Thank you.
how much longer does that have to go? Before-
Well, that's where you're shooting for. Hopefully they don't extend that. It's
Another 5 years.
another
Another
drug
3
is,
years?
I'm sorry.
Oh,
Oh, 2020.
As of right
Then
now,
it
but.
could be generic.
Okay.
Yeah.
Thank you.
Now, the other comparable drug is Xarelto, and that patent, at least at this moment, expires end of this year, like August or something like that.
Okay.
But keep in mind, it's not guaranteed that there's another company, generic company, that's gonna make generic too. And over the last 10, 15 years, you know, let's say the patent expired, not every drug gets picked up by a generic company. But hopefully, you know, again, you know, we live a very dynamic world where we don't know what the law changes. Like, you know, is it gonna be cheaper when it gets off patent? But I hope that answers your
Yeah,
question.
thank you.
Okay, and it varies from drug to drug too. I would say 90% of the medication you're taking is already off patent, you're taking generic. It's these newer drugs that's probably a lot more expensive than the generic drugs. So, the fact that this is your handout, and I won't walk you through, I won't go through every single category, like treatment for preterm labor, I don't think I'll go there. Okay? Now, as you go down, heartburn and reflux, that is a common medication class that our elderly patients usually on. They're usually on a PPI, like Protonics or Prilosec or the purple pill they call it. Okay, and there's like 3 or 4 other specific agent. Or if you're taking an H2 blocker, like famotidine is a generic name for Pepcid, and now having practiced a while, you know, originally ranitidine was Zantac, but now that's been pulled off the market, so Zantac now is famotidine too. So that's the most common agent for heartburn, upset stomach, or acid reflux. Okay, now what is the common side effects? And I listed, try to not list the whole long list, because if you listen to TV commercials, it will scare you to death. You don't want to take the drug because it lists so much. So I try to hit the main ones: headache, dizziness, might have diarrhea or constipation. It varies from patient to patient. So I'm not saying that if there's 5 of you taking the same drug, you might have different response. But as long as you know what's going to happen, you're not going to be, you know, as surprised that, oh, I got to use a restroom here, because that's the quality of life that you want to also maintain. So knowing your side effects of drug feeds into that too. The other agent is calcium carbonate or Tums. Now I'm sure a lot of the indication and use in here, I mean for our population, the elderly, is for calcium supplement, for trying to make your bones stronger and slow the osteoporosis process. Now, one thing that I would tell you is calcium carbonate is a generic name. If you buy the brand name, it's going to cost 2 to 3 times more. The generic work just as well, and even cheaper. If you have dinner another hour or 2, you can have dairy products too. But a lot of people don't tolerate that. So I try to minimize prescription. As a pharmacist, I try to minimize the use of drug, if you believe it or not. But that is optimal. I'd rather have you go through your diet and nutrition piece instead of supplementing with the specific expensive vitamins some of them are. So the reason I point out about Tums or calcium carbonate is that if you're taking that, do not take it the same time with your acid reflux meds. And the reason is because your stomach requires acid to absorb calcium. And I have given presentation in a hospital like 6 times a year for the last 5 years, is that you'd be astounded. I'm not going to have you raise your hand, that there's so many patients taking calcium supplement for the last 10 or 20 years, and you go in and see get an annual DEXA scan and finds out that, oh, your bone is still not you know, as strong as it used to be. And find out, when I sit down with my patients, is that they're underdosing themselves. It's not calcium carbonate, it's elemental calcium. So calcium carbonate usually is the bigger font, that's 500 milligram, let's say, but the elemental calcium is what's important. So you should be taking, if you're a female, 1,000 milligrams a day. If you're male, probably up to 1,200 milligram of elemental calcium.
You hear that?
So a lot of patients, and that's about 43% of the calcium carbonate. So read the fine print that's on the smaller font and towards the bottom of that label. It's not calcium carbonate, it is calcium, elemental calcium. Okay, so that's a pearl number 1 that I want to take away today. Okay, if there's no question, I'll move down to sleep aid. I'm going to go through pretty quick all these because there's so much medication. But right now, the sleep aid, when 20 years ago, a lot of individuals started on Benadryl. Because Benadryl is diphenhydramine, it's a long name, so people call Benadryl. Benadryl now is a poo-poo, or not, you don't want to use it. Hospitals now has gotten rid of Benadryl or diphenhydramine for sleep aid. And the reason is, in elderly patients, you end up having a lot more side effect. The anticholinergic, that's a long term. Basically, anticholinergic is you're gonna have something like urinary retention, dry eye, dry mouth, you know, just confusion. So you take it for bedtime. The next morning, when you get up, you can be really confused. So Benadryl is not being used for sleep aid anymore, just to let you know. And so what we have switched over is melatonin. Again, melatonin is a natural you know, chemical that our body synthesizes to sleep. However, it's not is effective as some other agent, but that's what we usually start with. In melatonin, you could buy small doses like 3 milligram, all the way up to 20, 30 milligrams. There's but usually I tell my patients start with 3 and go up more than 10. It depends where you go because they sell different strength of melatonin. They're different pharmacies, different stores. And then this is a prescription agent, Ambien. We're also shying away from Ambien. All these prescription drugs, we try not to encourage the use of it, especially in elderly population, because there's side effects. So some of the side effects, when you take these sleeping pills or aids, is sluggish or tired, get headache. And Ambien, you might even have altered behavior, severe confusion, and trouble breathing. Now these are not doesn't happen to everyone, but these are something to keep in mind. Yes.
Are Ambien and Trazodone similar? I mean, I know Trazodone's a sleep aid, so.
Yeah, Trazodone's another chemical, another agent,
Right.
but it's a prescription. It's different than Ambien.
Right.
But again, keep in mind, they prescribe these agents to utilize the side effect of the drug to put you to sleep. And so, yeah, Trazodone's another like antidepressant and stuff. Ambien is more of an anxiety. It was marketed or made for sleep, but there's a lot of side effects. Okay, great question. Please ask. Anybody else has questions? Okay, so if not, I'll move on. Okay, here is a little bit more specific. I already gone over a lot of these, but to make it more effective, I need to try to itemize or list the drugs that you might be taking if I would, as the name instead of the class. So, as I mentioned before, PPIs, which is proton pump inhibitor, omeprazole, you can buy over the counter. Most of these you can buy over the counter now. Prilosec is omeprazole, is Nexium. And just a little trivia because you're all pretty young out there. You've seen that originally omeprazole was a prescription, and the trade name was Losec. And then it got confused with Lasix because the same dose, so the FDA required them to change their brand name to Prilosec. They put P-R-I in front of it, okay? And that's because the doctor used to still write handwritten prescriptions, okay? Now it's electronic. And so that's omeprazole. And then when it came off patent, you did ask about patent, this is when drug companies got smart. Okay, I can't make money off a drug that's off patent, so they came out with another drug that has another brand name, and that's Nexium. Nexium is an isomer of omeprazole. So when this came off patent, Nexium came out. It's like, okay, doctor, you still continue prescription because the insurance company is the one that's going to pay for your prescription. But now that patent's expired, and now you can buy Nexium over the counter too. And then the other two that's commonly used is lansoprazole, which is Prevacid, and pantoprazole, which is Protonix. Okay, Protonix I don't believe is over the counter yet, but give it time. It's such a flooded market now that they're not going to invest in repackaging of it. Now, these are the most effective. Personally, I try to limit the duration of that. Now, I don't want to scare you. You're all sitting down, but I know so many patients it's on long term because that works. They continue taking the PPIs. What I have seen is that over time, you end up developing like osteoporosis, C. diff, which is loose stool and with a resistant organism. Those are higher risks when you take long-term PPIs. So what I usually work with physicians and tell my patients is like, hey, let's stop it after like 2 weeks or when the acute management is improved, then switch over to H2 blocker. H2 blocker is not as potent, the mechanism is a little different, but you can use like famotidine, which is like Pepcid or Zantac. And by the way, that's over the counter. So most of these is over the counter, which could save you some money. Okay. And then lastly, I mentioned is calcium carbonate, is Tums. Now, as you get older, our stomach is not able to produce the amount of acid for food absorption and stuff. So if your acid is decreased, your doctor might tell you to take calcium citrate, which is Citracal. Centrical does not require acid to be absorbed. So just to let you know, but Caltrate or calcium citrate is about 2 to 3 times more per milligram. So again, it's a little bit higher cost. But again, work with your doctor or ask your pharmacist. So that's heartburn. Here's the side effects again. I mentioned headaches, dizziness, diarrhea, constipation, rash, abdominal pain. Okay, so you're trying to take something that make you feel bloated and stuff, but the drug itself might have some side effect that cause you to have abdominal pain. So those are common side effects: heartburn and antacids. Okay, sleep aids I listed further. Diphenhydramine is the long generic name for Benadryl or Somonax. Okay, doxylamine, Zolpidem, which is Ambien, Lunesta, and then benzodiazepine like Restoril, Delmain, Halcion. I'm going to go with the brand name because you probably have seen that more. And then I got melatonin, and more currently, also recent drug is Remetil, which is Rosera. Okay, these are newer ones, but these are prescription. And again, we are trying to discourage our physicians to write these and see if you could, get by without that. Now, as we all get older, I know it's harder to go to sleep. It's harder to sleep, have REM sleep and stuff. Then it's an individual basis and work with your physician on that. Okay. Now this is where I mentioned before. Side effect lingers, and as we get older, our organ is just like an old car. I like to use the old car as an example. Your organs doesn't work as well. So first thing these drug requires is probably liver function, and then metabolize it, and then it goes to the kidney to eliminate. And those two organs, as you get older, doesn't function as well. And so if it doesn't function as well, guess what? It backs up. So you're gonna have a lot of these metabolites accumulating, and it start accumulating over time, like after a week or two. Elderly's now like, I can't even get up in the morning. So I strongly encourage, that's why we're trying to educate the public. Take sleepers when you have to, but don't take it chronically because it could accumulate. The renal function, which is kidney and liver function, does get worse as we get older. Okay, it's just aging process. I would love to have my black hair and a little thicker hair, but I'm not 21 either. And so that's how I use the example. You accept that, but the quality of life is going to be the key you want to maintain. So drowsiness. So dry mouth and eyes, this is where Benadryl comes in. The anticholinergic, I know it's a long term, but you get a dry mouth, dry eyes, urinary retention, difficulty in urination, and even constipation. Now those are very common side effects in the elderly. And when you see a doctor, let them know these are medication I'm taking so that they could piece the puzzle together. Otherwise, I've seen this a lot myself. You're gonna get 2 more prescriptions to counter these side effects. And over time, you start with 3 prescriptions, and in 5 years, you might have 10 or 12 extra prescriptions to counter the side effects. So we work with physicians too. Like, my residents, we work with physicians probably closer than anything, trying to let them know, because they don't know every side effect out there. Okay? Okay, changing gears, blood thinners. I think somebody mentioned about Eliquis. Aspirin, we lump it together as a blood thinner, but really, aspirin is really not a blood thinner, it's an antiplatelet. And all that means is aspirin will not allow your platelets to clump together. That's the first stage of like angina or heart attack, is your platelet starts clumping and then it blocks off, and then pretty soon you have a heart attack. And so aspirin is an antiplatelet. Now, if you've gotten a stent or some valve that's been placed in your heart, you're probably on aspirin or any of these blood thinners. Initially, we start patients on injectable, which is like heparin or Lovenox, which is a brand name for enoxaparin. There's generics out there now. And a lot of the retail pharmacy now stocks those injectable. What you do is usually you can get by with 1 or 2 doses a day on sub-Q shot. And so that's, and again, just common sense, when you take blood thinner, what's the common side effect? Bleeding. So when you cut yourself, as simple as a paper cut, it's gonna take longer to bleed. Nosebleed, especially now, especially this past week when we have the furnace burning and the air is dry, you're gonna have nosebleed. That's because of the environment, but then you don't have to, you have platelets that's not working, or you're on blood thinner, it's gonna be, takes a little bit more time to stop the bleeding. My tip to patients, if you cut your finger, raise it above your heart and put pressure on too. The same thing, nosebleed, just hold it longer. If it still doesn't stop for a period of time, then, you know, you need to call some for help, you know, 911 or whatever, but usually it should be, so, you know, bruising is a common. Some more common side effect is you run into a corner of a door or something like that, you can have higher chance of bruise, and it starts spreading. So in the next 6 to 24 hours, where did I get that dark bruise from? Well, keep in mind, you're on a blood thinner or a platelet or anti-platelet agent like aspirin. Now, when it gets really bad, when you have severe headache, red or dark urine, stools that is dark, that means you're bleeding within somewhere, okay? That's where you need to call for assistance. In a facility like this, you got great support system, just reach out and get people to help you. Ultimately, it's be 911, and you probably come to visit me in the emergency room, but I don't want to see you. I want you to be healthy, okay? So this is important too, blood thinner. Enough of that. I'm sure if you're on blood thinner, you've been already educated so much. You know, and then the old drug was warfarin. I did not list it up here. Coumadin or warfarin, that's dirt cheap, cheaper than anything, but you got to monitor your blood level. Make sure if your blood is too thin or not thin enough. Okay. Any question on blood thinners before we move on? Yes, sir.
Now, warfarin and Coumadin, they have an agent that it can clot if you have an emergency. From what I understand, Eliquis does not. So what do they do in the case of an Eliquis person who is having excessive bleeding?
Well, you did your homework. It's good. Good to know. You're absolutely, what this gentleman said is right. So there is a reversal agent for warfarin or Coumadin. Warfarin is a generic name, and Coumadin is a brand name. Okay, is that it's vitamin K? You can reverse that, and there's also other more expensive agents out there. And talk about warfarin. There's also lab monitoring. You could assess if you are too thin or too thick of blood. Now, switching over to the high-cost agent, Eliquis, Xarelto, Pradaxa, they do not have a lab test to monitor if it's too thick or too thin. But in the last 5-10 years, there's been reversal agent that's been out, and we could reverse that. But it is, the drug costs a lot, the reversal it would cost more. Okay, I'll just tell you. So there's good and bad. Now, my advice to physicians who I work with, and also elderly patients, or I'll just share my personal experience with my aunt, is that she was getting into 90s and her renal function was getting worse, and her cardiologist still wanted to start her on Eliquis. Okay, the problem here is that when do you know if your blood is too thin? When you don't have lab monitoring. And that's where I almost every day I have patients come into the ED and like they fell, they might have a bleed in their head, or they had a GI stomach bleed. That's the only time you know that your blood might be too thin, because your renal function is not clearing the drug. So again, it's important to educate you as a patient to look for. So when you see a doctor at least once a year, most of you might be seen twice a year for your annual physical. Ask them how my renal function is. It getting better or the same or worse? That way also gives you some idea how to monitor the side effects or issues down the road. Okay? Don't be afraid to ask your doctor for all these answers. Okay? The problem is the doctor is only, I got 5 minutes with you and it's overtime, I gotta run off. But that's what I've seen too. But anyway, yes?
Is there anything for comparison to Eliquis, or is that, that Because the doctors always say Eliquis. Is there anything?
Yeah, I think, I'll tell you, when this class of drug came out about 10, 15 years ago, it lightens the load for the doctor. Before this agents came out, everybody was on warfarin or Coumadin. But you have to go to the doctor's office or a lab at least weekly or monthly. And so the doctor's office doesn't want to see you again if I don't need to, so they switch over. That's my assessment, so it's my opinion. So it's not that all doctors are that way. But it's also convenient for you. You don't have to come back monthly or weekly to get your blood tests, bleeding time assessed. Now, there's still patients. We have an awesome anti-coag clinic at St. Luke's. It's staffed by 3 or 4 pharmacists. And they follow those patients because they might have side effects, like can't tolerate these newer costly agent, or they can't afford it. The most common reason they switch over back to warfarin is they can't afford it, $300-400 a script a month. Now, if you have insurance, awesome. But again, not everybody can afford that drug, and then this goes back to warfarin. So that's the kind of alternative that might be out there. And by the way, I'd rather have more monitoring, knowing that my blood is too thick or too thin, than not knowing until something bad happens. So I always try to go to pluses and minuses, you know. If there's a risk for me to bleed in my head and I don't know until it's too late, I'm willing to go to my doctor's office once a month to get my finger pricked and see like, oh, they're okay. Because as we all get older, our organ function changes, okay? And somebody keep that in mind. It's just Mother Nature. It's an aging process. Does that answer your question?
So they don't give you a test when you're on Eliquis unless you ask for it?
There's no test.
Oh,
That's why I said initially, gentlemen asked about, you know, reversal and stuff. There's not even a test out there. But they've done a lot of studies to show efficacy that this dosage works. But I might be the weird one out there that has, you know, a phenotype that is not appropriate. So they do have a test over in Europe, but I don't want to go off tangent a little bit, but not in this country, outside FDA approved. Okay? Okay. Let's go on to the next class of drug is itching, hives. As we all grew up, we get stung by a bee or get bit by an ant or poison ivy, the ultimate drug is Benadryl, diphenhydramine. That's great when you're young and stuff, but like I said earlier in the sleepers too, is that it will cause side effects. Dry nose, mouth, throat, and urinary retention and so forth. But we still use it if you have anaphylaxis or allergy. Okay, but one dose is not going to harm you as much as continually taking it. Okay, so that's that class. Hemorrhaging, I won't go into that. That's more of the OB, and also prophylaxis for epilepsy or eclampsia here. I mean, it's, you know, that's for the OB population. So the next page I think on your handout is, this is the comment. I could spend probably 3 days lecturing on these, but I will condense it to, you know, the time that we have. Blood pressure, okay? I'm pretty confident that, you know, a lot of you are on blood pressure meds. It's just because you've been diagnosed and you need to be on it, but there's side effects. Think about blood pressure meds. Most blood pressure meds, there's different mechanisms. So I should silence my own phone. Is that the way it works generally, again, there's like 10 different classes of antihypertensive drugs, but most of the time, one way of decreasing your blood pressure is vasodilate. When you it's just like a garden hose. You get too much pressure at the end, like now everybody wants, if it's warm enough, to wash their other side of their car because you don't want to get rust to get the salt out, right? But you got to crank that up, the hose up to get the pressure up. So there's 2 ways of doing that. One is cranking the faucet up so you have more pressure. That's similar to your heart. If your heart is beating faster, let's slow it down. So that's why you use beta blockers. Slow your heart down and your blood pressure drops, just like a garden hose. The other option is, which we don't have the luxury a lot, is have a bigger hose. Instead of a 1/2-inch hose, get a fireman's hose. Now, only the big hose, a fire station has it. That also will bring your blood pressure down. So drug-wise, we give another class of drug that vasodilate your vessels, and therefore your blood pressure drops. I use that because that allows my patient to understand why they're on the drug and how it works. So there's only two mechanisms. One is decreased cardiac output by turning a faucet down, and the other one's expanding your blood vessel and vasodilate. Now, what's the consequence of that? That's where we tend not to educate our patients. So when you vasodilate your vessel, when you get up too quick, guess what happens? Your blood pressure drops and you get dizzy, right? It's called orthostatic hypotension. That's a medical term. But layman's term is when you get up too quick, oh, I feel dizzy, it's because you have drugs that vasodilate. That's why a lot of drugs are blood pressure meds. We encourage a patient to take it before they go to bed, because when they lay in bed, they don't have to get up, stand on their feet. But as we get older, our thermostat, I call it, that tells the blood vessel to clamp down because you're standing up like I'm here. But when you get older, it's not as sensitive. So we try to educate our patient, take some of these that has side effect affecting your stability, take it at bedtime. Now the other class of drug is that beta blockers, okay? It slows your heart rate down. That's how you bring the pressure. However, you have side effects. You might feel a little bit, oh, I feel fatigued. I feel a little tired because your heart was pumping, let's say at 65, 70 beats a minute. Now it's slowing down to 50. So your acceleration, I call the heart is really like your engine in your car again. I'll use the cars now. When you accelerate, you step on the gas pedal and it goes up and you go faster. But when you let go, which is beta blocker, your heart slows down. And guess what? You're gonna feel like, oh, I'm tired, I'm not as, but after a week or two, your body adjusts and you can compensate for the side effects. It's because your kidney is able to, absorb a little bit more fluid and you're gonna be back to normal. But we try to educate patients, hang in there for a week or a few days, because your body will readjust and your blood pressure still will be low. Okay, I just gave you a couple of examples. So that's blood pressure meds. I won't go into it, but you feel dizziness, tiredness, flushing, dry mouth. There's other classes of agent that has some anticholinergic symptoms that I won't go into, but that's blood pressure. Okay, any question on that before I jump up to nausea and vomiting? I don't want to talk about it right before dinner, but we all get sick sometimes, the flu or whatever. Nausea and vomiting can be treated with drugs. I'm not a big fan of drugs. Again, I'm a pharmacist, I'm not pro-drug. Make sure you let the virus go out, because sometimes we try to speed up the process. Give me a prescription here, give me a prescription here. Pretty soon you're going to have side effects, which I'll get on here in a second, or just stay home and wait till the virus get out of the system. The main thing is hydrating. So these are the drugs like Zofran. Somebody probably heard Zofran is generic. The generic name is ondansetron, but Zofran is shorter. And transderm scope. I'm sure some of you go on the cruise and get motion sickness, but it has side effects. It's an anticholinergic again. Your eyes are dilated, you have dry mouth, you're confused, and you gotta wear 2 pairs of sunglasses. I experienced it deep sea fishing because I have motion sickness. It's like, and then afterwards, it's like, it's not the best trip. Not to say you didn't catch any fish, but it's just like, I have all the side effects, I have a scope patch, but also urinary retention, all that. So again, get the information from your pharmacist, if not your physician, because they are, won't prescribe you a prescription because you're going on a cruise. I'll get you a scope patch. But what do you have to look for? Okay? Because that could ruin your trip. Know the side effects. Okay. If you have other drugs like Reglan, Vistarel, and Finnegan, dry mouth, headache, diarrhea, these are all common side effects. Any questions so far? I'm going to jump. Next is antibiotics. Okay, we overprescribe. For the last 10 years, I think our physicians done a great job of not over-prescribing antibiotics. But when I was younger and before, oh, you came in, did you have a sore throat? Here's your penicillin prescription. Part of it is psychology of it. And this is one message, point number 2 that you can take away. Don't be surprised if you go see a doctor and he or she doesn't write you a prescription for your symptoms, okay? You might think you wanted an antibiotic prescription, but it might be a viral infection. A lot of patients over time that I work with, they get very disappointed because I had to sit in the doctor's office for an hour to get in, and the doctor saw me for 10 minutes, and then I could go back to work, whatever, and I don't have a prescription. After that one experience, you're not looking forward if it happens again, but it's education. If the doctor diagnoses it, it's a viral infection, I'm not going to give you a prescription. It's really a good thing, okay? However, we, on the other side, as a patient, like, hey, I didn't get anything and I got ripped off, whatever the term is, because you got to pay a copay too. Keep that in mind. So, antibiotic, I'm not a big fan, and as pharmacists, our role here is working with physicians, like, hey, we should start antibiotic, and the question is, how long? And that's one of the challenges now. We have patients on antibiotic that's far too long, and that's why we have collateral damage, like, oh, affects your GI tract, your bacteria is altered, so you're gonna have diarrhea or C. diff or other complication. The other thing that's really important, if you're on antibiotics too long, you have provided some opportunity for that bacteria that you have in your system to become resistant. I'm sure you heard of, MRSA staph is resistant, okay? I'm not saying all the cases are there, but what started this 50, 100 years ago, well, 100 years ago, they didn't have antibiotics, but when we start using too much antibiotic, the bacteria is smart enough to adapt to that antibiotic, and it becomes resistant 25, 50 years later. So those are things that we're trying to educate the community. It's like, don't, if you're not antibiotic, that's really a bonus, okay? And again, most common side effect is diarrhea. Rash usually is related to allergy, and most of the antibiotic we use nowadays is not penicillin based. There's other classes, so you don't, but still you have a risk for rash. Vomiting, headache, dizziness, and ringing in the ears. Those are just general side effects. If you Google it, there's probably another 150 side effects of antibiotics, okay? Any questions on this here? I'm wrapping up here because the time is, but let me focus a little bit of time on pain and constipation, okay? As we get older, at least I can speak for myself. If I talk about myself, I won't violate any personal information, but I'll share. As we get older, it's harder for me to get out of bed in the morning, especially on Monday morning when Saturday and Sunday, I mow the yard, I try to do a little extra work. I have conceded that it's part of aging. It's no fun, okay? However, if it's painful enough that you need something to get you out of bed, then you probably want to take some pain meds. So pain meds, again, are trying to avoid the use of narcotics. As fentanyl is a very potent painkiller, okay? In St. Luke's, we limit it to only in the OR and the ICUs. Because if you get a little too much, the patient will stop breathing, okay? And that's why patients out there that get tainted drugs is because they stop breathing, and what do? And that's what kills the misusers out there. I don't want to label them as drug abuser or whatever, but that's the thing. So I tried to discourage the use of narcotics, period. In 2025, I can tell you, are trying to discourage our physicians from not writing that narcotics, and they are compliant because now the government is putting mandate, like, you cannot do this or we will penalize you in St. Luke's. So I hate to call myself the narcotic police, but when a physician sends patient home on 2 opioids, which is the two narcotic, we get dinged. What it means is that the CMS is not going to pay us as much as, if you're compliant. But that's a separate discussion on that. So, so what we tend to use is, I encourage, is Tylenol. Again, I'm gonna tell you, Tylenol, I'll speak for myself, it doesn't work. But were we underdosing or not? Okay? Average population now is not 70 kilos. Did you know that when McNeil Pharmaceutical, when it came out with Tylenol, it's based on a 70 kilo patient. We have a lot of patients that's 100, 150 kilo, which means 100 kilos is 220 pounds. 150 kilos would be about, you know, upward 200, 300 pounds. We have a lot of individuals. If you still take the same number of tablets as somebody that's 50 pounds, not to say 50 kilos, right? So are we underdosing? And through our research and my experience in working with physicians, we got to give the right amount of drug for that right size of your body. And so Tylenol gets a misbrand or bad rap on that. And also, in the last 10 years, there's IV Tylenol, IV acetaminophen. It's not even Tylenol doesn't come IV, but acetaminophen does because it's a different brand. Also, ibuprofen, the NSAIDs, there's 4 NSAIDs. You know what NSAID? Non-steroidal anti-inflammatory agent. So if you have back pain or something, usually adults are encouraged to take an NSAID. But how many can you take? So you read the back of the bottle, you get Aleve or Advil or whatever, take 2 tablets every 4 to 6 hours. Doesn't work sometimes because your injury might be more severe. And then you see the doctor, you know what the doctor does? He writes, or he or she writes a prescription for 600 or 800 milligrams to 6 hours. So let me digress a little bit. 1 tablet of Advil or ibuprofen, generic name, is 200 milligrams. And prescription strength is 600 or 800 milligrams. Now, I'm not telling you to prescribe for yourself, but if you have acute injury, 1 dose is not going to hurt. I tell my family members and neighbors and friends, if you just fell off a ladder and you hurt, don't just take the 2 if you're 250 pounds. You might take 3, but don't take it every 6 hours. Just take 1 dose a day, get you up to that point, and you could tolerate by moving that ladder back into the garage. No, I'm just kidding. You know what I'm saying? But it's, those are common sense, but these drugs are fairly safe. The key here is we get older is that the most common cause is renal failure. So you do not want to take any of the NSAIDs long term. For 2 to 3 days, you're pretty safe. But if you take it long term, it's not just kidney that could get damaged, also increase the risk of GI bleed and other complications. So pain doesn't last forever. If it is, something's wrong. So you got to also rest, use heat, use other alternative therapy besides this drug. And a while back, people would just rely on drug. Give me the Percocet, give me the Norco or Oxycontin because I'm hurting. Well, that thinking has changed in the last 15, 20 years. So I just want to let you all know too, as we all get older, we will feel pain. It's just, can you tolerate it or not? And more importantly, I'll speak for myself, does that affect my quality of life? If I can't go to work because I'm still working, I'm working with my residents, and I can't move, I'm useless too. But if you can tolerate that, and only for a couple of days it gets better, I'll do that. So we try to educate patients, like after hip surgery or knee replacement, if you have pain on scale of 1 to 10, and if it's like 8, 9, or 10, let us know you need some drug to supplement that. But when that pain scale starts coming down to about 5, 6, or 7, you can start taking your Advil, your Aleve, or ibuprofen. And then a scale of 3, 2, or 1, can you tolerate that? Yeah, I would just hang in there for a day or 2, and it will get better. Because a lot of patient comes in the hospital, they expect, well, I just got my hip replaced, my knee replaced, I would expect a 0 on the pain scale. I haven't met anyone that has no pain. Well, I met them, but they never met me because they're still sedated. But you know what I'm saying is that also understand that you got to tolerate some degree of pain. Does that make sense?
Mm-hmm.
Okay, great. And I won't get into this side effect. And then constipation, very common, is we get older, our peristalsis and the GI tract, okay, it slows down. And guess what happens slows down? your food, your motility is decreased. And so therefore, you have a higher incidence and severity of constipation. So one thing to stay on top of is, keep track of how frequently you have bowel movement, but also know what your diet is too. Okay? Sometimes you have more fiber, it might help. The secret here is water is the cheapest. Even it comes in bottle now, so it's convenient. Is hydration helps that constipation to some degree. Okay, I won't get into the dinner time's around, so I won't talk about constipation. But anyway, if you take some of these drugs like Docalox, which is bisacodyl, a generic name, it could cause you cramping because the mechanism is that it stimulates your lower GI tract to have peristalsis. Now, if you have nothing there, that's really uncomfortable. And you have cramping that doesn't have any bowel movement. Okay? So again, be aware of that process. Okay. And these are some of the drugs that I touch on. I broke it down, I won't go through it again, but here's the common classes of drug for blood pressure, like ACE inhibitors. Lisinopril, enalapril, Vasotec. Most of these are generic, so that's why I use a generic name. The most common side effect ACE inhibitors is constipation, but also increased potassium. Okay, so again, I'm just going to give you a couple. Hyperkalemia is high potassium. Diuretics, Lasix, furosemide, hydrochlorothiazide is a water pill. Okay, that's just trying to tell your kidney to pee some more fluid out of your system. Then you probably will have to, by peeing out fluid, potassium comes out of the urine, and then you might have to have potassium supplement. Okay, but also you might get orthostatic hypotension, dizziness because you don't have enough blood flow. So these are all side effects of these drugs. We think it's benign because I'm just like a water pill. So you take a little too much, or you didn't have a good hydration over the last 8 to 12 hours, that might exacerbate side effects. Beta blockers I already touched on. Lopressor, Toprol is the two trade name, or Atenolol. There's probably 12 other beta blockers out there. I won't go into Carvedilol and so forth, Coreg, and so forth. But beta blockers that, when I use analogy of the faucet, it slows your heart rate down, therefore your blood pressure comes down. And also, if you have a heart attack, that is one of the main drugs that you should be on, along with aspirin. Well, there's like 4 drugs, I won't confuse you. But it protects your heart from having another second heart attack because it slows down the heart so that you don't have increased demand of oxygen. Because that's what causes heart attack, is you don't have enough oxygen to your tissue in your heart, and then you have infarct, myocardial infarction, or heart attack delayed people that cause it, okay? So beta blocker is important. And last one is calcium channel blocker, diltiazem, verapamil, nifedipine, a lot of side effects. Nifedipine, a lot of patient, I would say majority of patient that's on nifedipine or Procardia, over time they're gonna have swollen ankles and stuff because the way it works is that you retain a lot more fluid, and you're gonna have edema, swollen ankles and stuff. But I won't go into detail. So be aware of the side effects. Okay, and I already spoke about the pain meds. Again, NSAIDs, I put the trade name in, like ibuprofen, Advil, and Motrin. Naproxen is Aleve, and naproxen and naproxen. These are probably you can buy over the counter. And again, talk to your pharmacist. You can save some money there probably and time instead of going to the doctor's office. But I'm not asking you to self-treat, but I'm not surprised that majority of the individuals do self-treat. That's why they go to, my other handout is supplements and alternative therapy. But that's a discussion for some other days. But just ask your pharmacist, if not, your doctor. These are the side effects. I think that is it. I know my time is, up, but like I said, any questions? Let's just be fair. I know 5 minutes is over, and you might have dinner outside waiting for you. I'm willing to take 2 or 3 questions so everybody can learn from each other. And then, if you need time, I'll let you go and talk to you one-on-one. Any questions? Yes.
For arthritis, for pain, what is there anything that's better for arthritis?
Bone pain, arthritis pain?
Yeah.
Yeah, well, I think a approach. One is also, there's heat therapy, there's other elevation, but the drug that we use is usually NSAID, okay? Now, depends. This is what I've seen a lot, individuals that take NSAIDs long-term because they have arthritis, and then they end up, let's say, 6 months down the road with renal failure. So, if you are taking that, let your doctor know so you can monitor your kidney function closer. Okay, it's not a great answer, but I encourage therapy, keep active and stuff like that. I know it hurts, but it varies. The worst time of the day probably is first thing in the morning. It's bones are stiff and stuff, but that's aging. But if you know how to handle that, or treat that, that'd be great. Great question. Anything else?
There's also topical.
Yeah, I'm glad you brought it up. Okay, there's topical Voltaren and Aspercreme and all that. Again, communicate that with your doctor. Those topical does get absorbed systemically, but the reason I'm not into that is because it's not cheap. It's fairly expensive, but that is a great option. Is topical Voltaren. Turn on the TV, the commercials on all the time that you can use that. But if you look at the price, it's not cheap. Okay. Anything else?
Yes, question.
Yes.
On the blood pressure, what category is Benicar?
Benicar is, correct me if I'm my young pharmacist over there, but Benicar is ACE inhibitor.
Because I think it's olmesartan as well.
Yeah,
Yes.
it's a losartan.
Yeah, so it's an ARB
It's an
based on-
ARB ACE inhibitor in that class of, so it works on the renin. Okay, I get a little bit more too scientific here. What it is your renin is produced in the kidney and it causes vasoconstriction. Okay, so you take that and also vasodilate your blood vessels and decreases your blood pressure. But there is hundreds of different combinations of drugs, so I don't want, mind ask, big question. Okay, I should let you go. Thank you for being
Thank
here.
you.
That's it.